Right, good afternoon. Let's get started. Right, I'm going to give you some update and the new technologies in CT. So number one, as technology get better, one of the things that the CT scanner is getting bigger. Not that you can tell from outside, but the inside is actually it's getting a lot bigger. So just to give you some reference here, the workhorse of this coronary CTA is performed with the scanner with 64 slices. 64. So basically, you have each detector assembles 64 of them together. Okay, fit into right here in the scanner. Okay. So each detector, the width is 0.625. So if you have 64, that detector that amounts to about 4 centimeters. Okay, so the width of this detector is total is 4 centimeters. So each time you rotate, as you can see, the heart usually a normal size heart in the longitudinal axis is about, depending on the size of the person, could range from 8 in a smaller person up to about 15 to 16 in a larger person. So 4 centimeters really doesn't cover the whole heart. In order for us to cover the entire heart one single rotation of the scanner, you need to have a scanner who cover at least 16 centimeters. And that can be achieved by having a 254 detectors with a width of 0.625 or 320 detectors with half millimeter each. So the result is from about 10-15 years ago, 64 slice detector CT of 4 centimeter coverage. Now we have two vendors who have, it's called wide detector CT, that each one rotation covers 16 centimeter. The single rotation can cover the entire heart. So this is the top is how all 64 slice CT, 64 detector CT does. So you require about 6 to 7 rotation, depending on the heart rate, to image the patient. You can imagine a lot of things could happen in 6 to 8 seconds, depending on how cooperative the patient is. As you can see, with the wide detector CT, essentially, image is acquired in one single rotation. All right? So basically, you don't need to stitch all those images together. And since you're exposing the patient in only certain part of cardiac cycle, the radiation dose is much lower. So basically, this is how we use acquired cardiac images using 64 slice, 64 detector CT. Now with the wide detector CT, you can just one single shot get the picture. Before we need to stitch 4 or 5 images together, you can see unless the heart rate is perfectly stable, you're going to get some what we call stitch artifact or step artifact when you put all the images together. So with the wide detector CT, that's no longer an issue. It's a similar comparison, and we're taking a picture in the medical center. Okay? So, and that's what I was talking about. So you get this what we call step artifact, and that means the top part of the chest is not imaged, and the bottom part of the chest are imaged at a different time, and that has implication for perfusion imaging, obviously. And you can actually, with 3D reconstruction, you can see this is actually where the different slabs are stitched together. And on the right-hand side, since with the wide detector CT, the whole heart is imaged exactly at the same time, so there's no more step artifact. Everything looks uniform, single rotation at the same time. The perfusion is synchronized, so you can assess visually better compared to this here, typical example, right? Here, not because you're getting more contrast here, just because the timing, the bolus just happened to be around here. By the time it gets here, there's less contrast. So it doesn't mean there's a perfusion defect, in these slabs here. Okay, so that's a potential application, but So you all heard about, how many, what's a CT scanner? Someone bragging how big, how good your cell phone is, how small your cell phone is. People brag about how big their CT scanner is. So you talk about this release, 640 slide CT. I mean, and this was released in 2013. So is it really? I mean, if you think about it, so 320 slide CT that I mentioned earlier is 16 centimeter. Is this 640 slides? Is it 32 centimeter? I mean, you can imagine how big the scanner would be, right? So the truth is, this is mostly just for marketing purposes. It's actually 320 detectors, and using some electronic sampling technique, you can generate 2 slices for each detector. So when you talk about, when someone asks you, okay, what's your CT scanner? Instead of how many rows, how many slices, how many detectors, you ask exactly how much the coverage. So if you have the coverage, you know exactly how big the scanner is. Okay? Because the number of detectors is not the same as the number of slices. Usually, number of detectors is how many actual physical detectors you have, all right, which go from 64 to 320, no more than that. Maximum number of detectors the scanner fit is 320 detectors. But number of slices you can increase by manipulating the sampling process. So in CT, we like to talk about Z-axis coverage. So XY is in the actual plane, and the Z-axis is the longitudinal plane. So you want to see the wider the scanner, the more the Z-axis coverage. So this is example of 16 rows or 16 detector CT is 1 centimeter, so it's really thin. So it takes about 20 seconds scan. And so this is the first multi-detector CT that was able to do reasonable cardiac work. You can imagine if you need 20-second scan, there's probably a lot of artifact, right? So this is the workhorse of the CT most of the places have. And then, you have 8 centimeter with Philips, and then this is the Toshiba or GE. So you can see the differences. So you really want to ask about what's the Z-axis rather than, how many slices my CT has. And most of the vendors use this called Z flying focal spot technique. Essentially, electronically, they can manipulate the focal spot in longitudinal direction, or Z-axis. You can double the number of simultaneous acquired slices. So if you have 64 overlapping with 0.625 millimeter slices, you can double that. Each detector is able to generate 2 slices. Is there any advantage? I mean, the problem is, theoretically, you can say that the resolution is better. Instead of 0.6, now it's 0.3. But the truth of the matter is, remember, CT, we entirely rely on the signal attenuation, right? So if you think about 0.3 millimeter, it's very thin. In order for you to generate some reasonable signal and to avoid the noises, you need to give a lot of radiation. So practically, practically, there's no use to generate a 0.3 millimeter slice because you really are not going to have too much signal. So unless we have new technology coming along, I think the true useful width of each slice that you can get information from is 0.6. So that we get out of the way. So when you go out there interview for a job, ask specifically because that could be quite confusing. Okay, so the scanner is also getting faster. You can see that heart moves. So we really need to freeze the heart in order to get information. Otherwise, we get what we call motion artifact. And this is depicted here, RCA. You can see it moves really a lot. If your camera or your scanner is not fast enough, you're going to get what we call motion artifact. Okay. So basically, you see blurry. Everything's blurry. So the temporal resolution is determined by how fast you can spin this scanner, the gantry rotation. The gantry rotation, since CT is you only require half rotation, because you can project the data from the opposite angle and generate the entire sets of images. So you don't. So the temporal resolution is actually how long it takes to rotate half of it. So the temporal resolution of a scanner is half of what the gantry rotation time. Okay. So typical scanner is about 280, 270, the newest generation. So the temporal resolution is we're talking about 130, 140, 150 milliseconds. Okay. You can see, to give you a comparison, a regular cardiac MRI we're talking about an order about 50 milliseconds. So it's really not optimal for cardiac imaging, for small structure especially. Okay, so older generation scanner that we had, Philips, the rotation time is 400 milliseconds. So we have basically temporal resolution of 200, which is, I think, it's worse than suboptimal. The newest scanner, again, 250 to 280. As you can see, you cannot really, this is like 2 tons structure. You really cannot spin it a lot faster, I guess. As you can see, the amount of force it generates is tremendous. So if instead of 1 detector, I put 2 detectors there. So instead of rotating 180 degrees, which is most of the scanner do, now you only have to rotate each scanner 90 degrees. So you actually can effectively half temporal resolution, like in this dual source CT that we have upstairs. Since the rotation time is 250, divided by 4, basically give you 62 milliseconds, which is a lot better compared to, for instance, MRI, and it's probably as competitive as compared to 3D echo, for instance, whole volume 3D echo. So other progress is what we call high pitch mode. So you can, the left hand side, the standard helical mode, you can see, can tell the scanner is moving. But in the right hand side, you can see how fast the scanner moves. And that's only possible if you have 2 detectors. Okay? Otherwise, if you have 1 detector, the scanner is not fast enough to acquire the data. So you're going to have a lot of gaps in your. So if you have 2 detectors, you can afford to if the heart rate is slow enough, you can afford to move the table faster. And by moving the table faster, obviously, you expose the patient in much less radiation, and less likely the patient is going to move, less likely the patient is going to breathe, and so you get usually image quality is better. So you can see this table can move about 87 centimeters per second. So this is totally opposite from a traditional tedious cardiac MRI. So this can be done. You can imagine that whole bad if someone who is 6 feet, who is about 180 centimeters, you can scan from the head to the toes in less than 3 seconds. Whole body scan in less than 3 seconds. So essentially, what we have upstairs, this is called dual source CT because we have 2 detectors, and with high pitch flash mode, so you can a good temporal resolution, 62 the best in all the CT scanner, and this possibility of scanning the patient in really quick fashion. Essentially, to scan the heart, you only need about 1/4 or 1/3 of a second. And that opened the possibility of what we call free breathing cardiac CTA, especially for congenital. Not much for adults here, for pediatric population, for kids with congenital heart disease. This is really a big advance. Even for us, if you have a patient in ICU, let's say in a ventilator, but if you time it right, you can really basically, there's no motion issues using which flash mode. So they don't really need to cooperate and hold their breath, even stop the hold the ventilator. You can just put them in the scanner, and in 300 milliseconds, for most of the cardiac structure, that's enough time for coronary imaging. It really depends on the heart rate. Again, for instance, this is a case that we did. This is a relatively small lady, obviously, and this is, I think, 1 month after we had the scanner. So this is not from the company. It's actually our patient. So this scan was performed in 1.4 seconds, and for 85 years old lady with aortic stenosis, short of breath, I think is much more comfortable. How long it take to read is a different story, right, Eric? Okay, so other thing is really CT scanner is not only is bigger, faster, is also really much smarter. I mean, there's tons of software advances. Obviously, we can't go through everything, but for us and for general cardiology audience, one of the things that you really cares about radiation, right? And radiation is determined by the tube potential. So standard cardiac CT, we use 120 kV, calcium score, even chest X-ray that we use, okay? It's 120 kV. The higher the kV, the higher the energy, higher the radiation. And so if you can lower the kV from 120 to 100, you save about 40% reduction. And there's a recommendation from the Society of Cardiovascular CT is you should strongly consider using 100 kV. And the patient is less than 90 kilogram, which is about 200 pounds, or BMI less than 30, which, I think even we joke about how big the people in Texas is. I mean, I think it's a good number of patients fall into that category. And now almost every scanner, you don't need to be the latest generation scanner, have the capacity for you to change from the 120 kV to 100 kV. Obviously our new scanner allows you to go down even further to 9 to 70. Okay, so just give you an example. So this is two males, both of them have similar BMI. You can see the image quality. So basically, you can tell from the image quality, what's the energy that you give. It really depends on the body shape. So the size, BMI is only one thing. Just to tell you that, patient with the same BMI could have a larger chest area, for instance. And so basically all the new scanner has this what we call automatic tube current. What happened is they do a scalp films, and they can computer algorithm look at the chest area, cross-sectional chest area, and where the heart is supposed to be, and give the recommendation in terms of what would be the best kV. And you can override it, but this has been done in phantoms and multiple clinical studies. So ours is this machine is probably smarter than you in choosing most of the time, not every time, but yes, Rob.
Do you know how much does one of these CTs compare to a 5-second DSA run catalog, or a whole heart cath? You should basically do a whole heart cath, right? How much
what?
How much energy or radiation exposure is compared to
a regular cath? A regular cath, there's some data is about, I believe, 5 to 10, depending how many shots you got. And
5 to 10 CTs?
No, 5 to 10 millisievert. Again, CT, what we do, CT range from, I'll show you some example, range from less than 1 to 20. So the cath lab is very standardized. Excuse me. It depends really, the major thing is how much fluoro time, right? If you zoom in, right, and then you get more, and how many pictures you take. But I think standard cath, regular standard view, I think is 5 to 7 millisievert. Okay, this is about twice as how much you get from the background radiation. Okay, and CABG patient, if it's difficult, sometimes you go up to 15, 20, right? So CT is very variable. It's much more variable than that. I think cath is more standard. So anyway, so everything, this is basically comparing using this smart algorithm. You can see that it doesn't show up very well. So basically, patient who has smaller patient usually get less radiation, and the thicker patient in this and higher BMI, actually using the algorithm, you end up using more radiation, which kind of makes sense, right? Because to optimize the images, you want to give radiation to people with big chest. Okay, so that other significant changes is when you do the scan, you can alter the type of scan mode, go from gated to non-gated. So obviously you can do what we used to do, TAVR, just gated all the way through with an old scanner, a lot of radiation, and only one vendor, or you can take hard gated and the peripheral vascular non-gated, but this will be 2 scan, 2 bolus injection, so not so great either. Ideally, you can want to do gated the chest and then non-gated the rest of the body, because really from hearts down here or the vascular, it doesn't move too much. So this help, but most of the vendors do have this feature. So radiation dosage. Just give you all heard about PROMISE trial, right? Compare CTA to standard stress test technique. So it was presented last year, 2015. So essentially, the study was done in the beginning of for 2010, 2014, or so on. So I would say overwhelmingly majority of scanner was 64 slices CT. So minimum exposure was 10 millisievert. Okay, so that's kind of what most of the people get with 64 slices CT for coronary work. And the Scott Hart trial, which was presented, I think, a little bit same year, but a little bit later, but the study was just published in Lancet. They have more newer scanner, white detectors. Instead of 64 detectors, they have a lot of 320 detector CT. And the difference also, I think, also they have one of the investigator was very diligent in educating the sites with those reduction technique. So this is what a clinical trial 4 millisievert is. I think it's a good parameter for you to achieve in regular coronary CT work. I mean, different from TAVR, obviously. You're just talking about a patient come in that you want to do coronary CTA to detect coronary disease, okay? So 4 millisievert. Obviously, there's a lot of publication using all these new features, beautiful pictures you can see there, very small dosage, basically for coronary angiogram, the same as 2 mammogram, 10 X-ray. It's real. I mean, it's possible. I guess the picture might not look the same, but this is the scanner, the new scanner we got. The picture, some scan from our new scanner. This is like 1 month after we got our scanner, and this guy, you can see that he's not big. I'm not as old, but I'm about 5'6", 150 pounds. You can see if you can lower the heart rate to 50, 60, which is probably doable with a little bit help, a beta blocker, you can achieve this image quality, obviously more than diagnostic. This patient had, I think, equivocal stress test and atypical symptom. 0.65 millisievert, which is about 2-3 months, okay, of your background radiation. So it's really changed the paradigm in terms of radiation. And this is a study we just done, I think, just a couple of months ago, a patient with a stent. You can see 0.6 millisievert is using 80 kV. Okay. Well, having said that, the key is, bottom line is, you might have heard of our new scanners, better temporal resolution. The key is still, if you want the best result, you need to still control the heart rate. So this is important. This study that was published look at the diagnostic accuracy of CTA, where everybody get less than 1 millisievert, which is about 3 months of radiation. And diagnostic accuracy compared to invasive angiogram, obviously it was published. It was excellent, but mostly not big people. and they were using nitroglycerin in almost everybody, actually, and 92% beta block with the heart rate of 58. So for the fellows, if someone with a coronary is young, okay, like this morning they put someone in a scanner with a heart rate of 70. The guy was 37 years old. Okay, and now those patients, we should, before we put in a scanner and just give IV, we should try to give some PO, let them lower to 60s at least, less than 60, even better before we put in a scanner. Otherwise, you're going to get stuck. You want to provide the best result with the least radiation. You need to prep the patient well. I think we go overboard before we have the patient there for 3 hours, try to lower the heart rate. Now with the new scanner, we think it's so good. We don't have to worry about it anymore. We just give them IV on the table. No, that's not the case. So remember, if the young patient, you want a very low dose scan, you need to lower the heart rate to 60, low 60, high 50 will be optimal. So give them some PO before we go. Okay, so there we go. Rob, answer your question. Min receiver, invasive angiogram. This is European. They might not be as good as American. So 14 plus minus 10. Okay, and CTA. Oh, again, this is but even twice or 3 times more. This is using all the tricks, super selective patient, But typically, you can have, let's say, 40 years old women, or 40. I don't know, you rule out dissection or whatever you want, or 40 years old male with chest pain. Like I always like to tell the story of one of my fellows when I was a fellow. Guy's a little bit older. He's about 40 years old. He's from Russia, and he was on call. He was having he believed was angina pain. It was typical pain, and he had some hypertension, hyperlipidemia. And so he went himself and called the cath lab director. So he came in the middle of the night. This was the county hospital, and between both of them, they did a cath without calling anyone else, because county hospital, no one works at night. But anyway, for instance, that he probably got, I don't know, 8, 10 millisiever, the cat. But even so, the new scanner, we probably can get away with doing him with less than 1 millisiever. In the contrast, I think this is probably average. I think maybe less in the real world. Anyway, so. The other thing is the contrast volume. With the new scanner, we really can get away with less contrast. We used to use 100 cc of contrast. Now we routinely use 50, 60. Okay? And the reason is CT, all you do is you try to image the contrast bolus. Okay? If you can scan faster, cover more area, you don't need to wait. You don't need to follow the contrast. So you don't need to opacify the entire vasculature. You're going to only have to opacify certain part of vasculature, and if your scan is fast enough and big enough, you can follow the bolus. Basically, less time in imaging the vasculature, less contrast you need. Okay. And this is with the 320 slice CT detector CT, you can do a CT angiogram with 40 cc of contrast, and this is a different story we can talk about next time, dual energy. And in Europe, where the Ottawa protocol, they don't really, there's controversy between, annular size selection, systole, diastole. And I know in Central and Europe, they don't think clinically matters. Obviously, the size in systole and diastole is different, but the difference is probably not big enough for you to alter the size of a prosthesis you put in. So they basically don't care. So they can do what we call, the flash ultra-fast protocol. Usually you get whatever you get, diastole, and they can scan the patient real quickly. For instance, in this patient, in about less than 2 seconds, and in this case they use only 30 cc of contrast. We're not. Obviously this is case report, but even for TAVR we used to use 150 cc. Now I think we're using 70 or 80. So effectively lower half the dose of contrast. So just to give you some reference, okay? So the standard 64 slice, the temporal resolution is about 150 to 200 milliseconds. The new scanner is between 65 to 120, 130, okay? Scan time before, takes about 4 to 8 seconds to finish the patient. Now with the white detector CT and the dual source, you can less than 1 second. In the radiation, optimal scanning condition, you can achieve less than 1 millisievert, but at most maybe 4 or 5 millisievert in most of the patient. And you can use half of the contrast compared to 64 side. But still, heart rate control is still optimal. So this is, I like to show this slide because there's really, I think, before we only talk about it, but I think right now it's real that for assessment of CAD, with one caveat I'm going to say, I think, you can look at stenosis, you can look at the plaque, not totally quantitative way, but semi-quantitative. You can get functional imaging, you can get perfusion, the CT-FFR. The only thing that CT can do, but definitely not as the first line of technique, is like late hyperenhancement, okay, for scar detection. It's possible, it's been validated, I guess, MRI, but the study quality is not as good. But essentially, if someone need to have with suspected CAD, I think the latest ACCHA guideline in terms of workup patient with chest pain, controversial or not, compared to functional testing, CTA has been put in a much higher category than it was a couple of years back. Essentially, you all read a lot of CT, and if you do it well, sometimes it really simplifies the workup. Okay, so in summary, it's bigger. We have white detector CT. It's faster. It's fastest gantry rotation, dual detector, flash mode. You can do adaptive acquisition, sort of intelligent selection of tube potential, so tailored to each individual instead of just giving everybody the same radiation dosage, and potentially give you functional information is really the next frontier. Anyway, any question? Question? So how many scanners out there with 350? So Toshiba scanner is 320 detector. There's about a couple hundred in US installed. They're the first one in coming up. GE has 256. So they're the same size. They have 16 centimeter coverage. So one single rotation. So those, they came out last year. I believe there's only about less than 10 installed in the country, being used clinically. I think we had one here, but there are some issues. So Siemens has dual source CT. How big is our dual source scanner? Anybody know? It's 2 detector, right? How big is each one? So I say Toshiba, the top of the line covers 16 centimeter or 320 detectors. Each detector is half millimeter. 0.5 times 320 give you 16 centimeter. Okay? GE is 256 times 0.625 give you 16 centimeter. So the detector, when you look at it, is 16 centimeter wide. How big is the dual detector CT? Same, smaller? Imagine the technical challenge to put in 2. Let me see. So this is what a 64 detector's head, each head. I say detector, right? But each one has each smaller detector. So imagine this is 64. Now it's 4 times bigger. Obviously, everything's more compact, right? It's very hard to fit two of this in the same place. So each detector of our dual source CT is actually smaller because space limitation, right? And that's one of the main problems with dual detector CT. Dual detector, the flash, the top of the line we have upstairs, has 96 detectors each. So that covers 6 centimeters only. That's why we still have step artifact, technically, right? So only scanner that doesn't have step artifact are the one with single rotation, 16 centimeter coverage. So the newest scanner with the dual source is 96 detectors, and the vendor is going to tell you, yeah, it's 196 slices. You know, remember what I told you, right? Sounds impressive. 2 times 196, that's what? Almost 400 slices. But that doesn't really matter. The true coverage is 6 centimeters. Most of the dual source scanner in the country, there's 100 of them, is a prior generation to the one we have. It's 2 detectors with 4 centimeter coverage each. So 2 64 detector CT putting together. Okay? So smaller but faster versus Toshiba or GE. They're bigger, it's a little bit slower. So if you go out and practice, I would say Toshiba white detector CT is much more available. It's been around for 4 or 5 years. They're a lot cheaper too. And actually,
why did you not buy it?
Huh?
Why did you not buy it?
Toshiba, because we believe we care more about temporal resolution. The temporal resolution is 130, 140 millisecond. And our new scanner is 65. That's half of it. So, and you know, most of the step artifact is not a big problem. Perfusion, obviously, if you have synchronized uniform perfusion, is better, but you can still do perfusion with 6 centimeter coverage. You can, if you want to focus on single vascular territory, 6 centimeter coverage is reasonable. Plus, our scanner can move this, has what we call shutter mode. So it only covers 6 centimeter, but since the table moves so fast, you can go up and down real quickly. It's so fast, it's 87 centimeter per second. So if you want to cover 12 centimeter of a myocardium, it's almost at the same time. Almost like it's not synchronized, but the perfusion is almost with milliseconds difference from one rotation to the other. So, but you all cardiac CT. I mean, really the coronary motion is really the most important component, right? Step artifact is, I think, is relatively easy to get around with it. Okay.
Does CTFFR require a dual source?
No. The first study was done with 64 detector, and they have some follow-up study using dual source, better generation, some Toshiba white detector. The follow-up study looks better because FFR CT really depends on the image quality, like anything else. If you model something, you want to be as close as possible to the real coronary anatomy. Yeah. But the answer is, the only thing you need is 64 slices with a good image quality.